At Penn Medicine, we want to provide you with the best experience and the latest information on prostate cancer as possible to empower you to make wise decisions for you and your family. To discuss the best treatment options, patients usually need to complete the following: the last PSA test, the biopsy result, imaging results including an MRI or bone scan. In order to understand prostate cancer, we have to understand the biology and aggressiveness of the cells. The Gleason Grade informs us of how aggressive the cells are. The higher the number, the more aggressive the cancer. The cancer grading system starts at grade 6, which is the lowest and least aggressive type of prostate cancer. A 10 is the most aggressive type of prostate cancer. For grade 6 prostate cancer, there is little to no benefit from treating it, and therefore it's recommended to watch it under a surveillance program. If you have a grade 6 prostate cancer, you might be eligible for the surveillance program and might not need to undergo cancer treatment. For grade 7 to 10, treatment of some type is recommended to ensure it will not spread. A word about biopsy reports. If you look at the biopsy report, you will see two numbers that are added together, like a 3 plus 4 equals 7, or a 3 plus 3 equals 6, or a 5 plus 4 equals 9. The first number tells you what the majority of that prostate sample had, and the second number tells you what the minority or the rest of that sample had. So, a 3 plus 4 equals 7 prostate cancer is less aggressive than a 4 plus 3 equals 7 prostate cancer. If you only have cancer of the prostate and it has not spread, you might hear about a lot of treatment options such as microwaves, lasers, freezing, burning, and ultrasounds, or HIFU. None of these options have cure rates as high as or for as long as either surgery or radiation. When deciding between surgery or radiation for prostate cancer, you really have to consider 4 things: the chance of cure, the risk of urinary incontinence, the risk of erectile dysfunction, and the risk of long-term complications. Multiple studies have shown that cure rates are the same between surgery or radiation. However, quality of life may differ during and after treatment depending on the treatment option. For example, the risk of urinary incontinence and the risk of erectile dysfunction are both slightly higher for surgery than for radiation, while the long-term complications can be higher for radiation than for surgery. When the whole prostate is removed in surgery, there is a 5 to 10% risk of long-term urinary incontinence, compared to less than 1% for those undergoing radiation. The reason for most urinary incontinence cases after surgery is due to the male anatomy. In males, the prostate is right under the bladder, and the sphincter is right under the prostate. When the prostate is removed, all that is left is a weak urinary sphincter that will need to be strengthened to block the flow of urine. In recovery, diapers or pads will be needed, and they will likely need to be changed 6 to 8 times per day. On average, it can take 6 months to recover to the point where pads are not needed. However, if you are younger and healthier, or if you have excellent urinary function before surgery, you could recover as early as within 1 to 2 months. Each person is different, and it is very difficult to guarantee results. 5 to 10% of people undergoing surgery may never get that same level of continence back and might require a simple but highly successful procedure to add support under the urethra. The risk of erectile dysfunction is higher after surgery than radiation. However, the results also depend on your current erectile function. The better it is now, the better it is to maintain function afterwards. The location of the cancer also plays a big part in recovery after surgery. If the entire tumor is located inside the prostate, then it may be possible to perform a nerve-sparing surgery to spare the nerves that go to the penis and cause erections. Even with a perfect nerve-sparing procedure, erectile dysfunction is still possible after surgery because the nerves and blood vessels could be impacted by scar tissue. Erectile function may take as long as 1 year to fully recover. Both the urinary incontinence and erectile dysfunction are higher risks with surgery than radiation. The risks following radiation treatment are higher than surgery risks starting around 5 to 10 years after treatment. These risks include getting a second type of cancer, such as bladder or rectal cancer due to the radiation exposure, treatment effects on surrounding organs, and treatment options if there is recurrence. There are also low risks of damage to the bladder or rectum that can cause bleeding or pain when urinating, or an urgency and increased frequency in going to the bathroom. Radiation can damage tissue, making these late-onset issues difficult to treat. Radiation treatment is not recommended for those with irritable bowel syndrome, kidney transplants, or intestinal bowel surgery. Radiation oncologists and surgeons usually recommend that younger men receive surgery over radiation as they are more likely to recover and live longer. Since older men in their 80s or 90s may not live longer than 5 to 10 years, the possible risk of long-term side effects from radiation are relatively low compared to someone in their 50s or 60s who would be much more likely to experience potential problems. It can be very difficult to decide on treatment options. And remember that results after treatment cannot be guaranteed. But we hope we have provided you with enough information to make a good decision. Have a question? Come prepared to discuss your questions at your next office visit or call us at 215-622-2891.